tackling a really critical area. Understanding the medications used to manage myasthenia gravis.
Yeah, it's a complex topic.
Definitely. We've got this detailed document here. It's almost like a roadmap of the drugs for MG, and our mission really is to unpack it for you.
Make it clear, step by step.
Exactly, like building your knowledge from the ground up. Think of this as the essential guide, not just what the drugs are, but how they work, why they matter in practice.
Right. We'll take all this info and structure it so it's actually useful, especially if you're, say, learning about this or working in a clinical setting.
Okay.
We'll start big picture, how drugs are used, then zoom into the specifics, the categories, mechanisms, key things to watch out for.
All right, so let's dive right into this roadmap. Our document kicks things off by looking at the different roles drugs play in managing MG. It sort of breaks it down into 4 key areas. First off, medications for symptomatic relief. What's the main goal there? What are we looking for?
Well, the immediate goal is just boosting that communication, the signal between nerves and muscles.
Okay.
Think of it like turning up the volume on a weak signal temporarily, and the classic example is acetylcholinesterase inhibitors.
Right. Then we have immunosuppression. Now, it sounds like we're shifting gears, not just treating symptoms, but tackling the underlying problem,
Right?
the body attacking itself.
Precisely. Immunosuppressants aim to dial down the immune system's attack, specifically cutting back the production of those autoantibodies that are, the hallmark of MG.
Okay.
This includes drugs like corticosteroids, azathioprine, things like that. So symptomatic relief helps now, but immunosuppression is more for the long haul.
Got it. Third category, drugs for acute crisis management. This sounds like the emergency toolkit, right? When things suddenly get much worse.
Exactly, a myasthenic crisis. Muscle weakness can become really dangerous, even life-threatening, especially affecting breathing. So you need rapid action. That's where treatments like plasmapheresis or BIVG, intravenous immunoglobulin, come in. Sometimes biologics, too, for immediate support.
And the fourth area is thymoma management. Often involves surgery, right? How do drugs fit in there?
Yeah, so if a patient has MG and a thymoma that's a tumor in the thymus gland, removing the thymus, a thymectomy is often key.
Makes sense.
But after surgery, you often still need immunosuppressant drugs to manage any ongoing MG symptoms. So surgery gets the tumor, but meds help control the immune response itself.
Okay, that gives us a really clear overview of the different angles.
Right.
Now, the document then lays out a classification of these drugs. It's like a table listing the types, specific examples, even some brand names you might see, like in India.
Yeah, this table is super helpful, like a quick reference.
So what's on it?
Okay, top of the list. Acetylcholinesterase inhibitors, like pyridostigmine, often called mestinon. These are the go-to for directly boosting muscle strength.
Then corticosteroids. Prednisone is the big one, right?
Oh.
Sold as Wisolone sometimes. Essential for broad immunosuppression.
Exactly. Following those, you've got other immunosuppressants, azathioprine, maybe Imuron is the brand, or mycophenolate, Cellcept. Different pathways, but still reducing that immune attack over time.
And then we get into the more targeted stuff. Biologics like rituximab MabThera and eculizumab Soliris. Sounds more specialized.
Precisely. Rituximab goes after B cells, the antibody factories. Eculizumab targets a specific part of the immune system called complement, often for tougher cases.
Okay.
And the others category includes things like IVD Globuplex is one brand, and plasmapheresis, often used in those acute crisis situations we mentioned.
The document also has these useful keynotes for each class. For pyridostigmine, it says it's usually first line for symptoms and, importantly, avoids excessive muscarinic effects. What are those, and why is avoiding them good?
Right, so acetylcholine doesn't just work at the muscle junction, it works elsewhere too, causing what we call cholinergic or muscarinic effects. Things like extra saliva, sweating, gut cramps, slow heart rate. Pyridostigmine helps the muscles, but we want to minimize those other systemic side effects for patient comfort, make it easier to take long term.
Makes perfect sense. For prednisone, the note mentions high doses for crisis, but then this really crucial slow taper. Why is that slow reduction so vital?
Well, when you're on high-dose steroids for a while, your own adrenal glands kind of go to sleep. They start making natural cortisol.
Oh, right.
If you suddenly stop the prednisone, your body can't produce enough cortisol on its own. That leads to adrenal insufficiency, which is serious. A slow taper lets the glands wake back up gradually.
Definitely critical to remember that.
Yep.
Okay, rituximab's note says it targets CD20 plus B cells, used in refractory MG cases that haven't responded well. So it's like a plan B
Yeah.
or more specialized.
Exactly. It's a more focused attack,
Yeah.
depleting the specific B cells, making those harmful autoantibodies. Yeah, a targeted immunosuppressant for more challenging situations.
And eculizumab is highlighted for anti-AChR, antibody-positive MG. So it's really specific to a subtype.
Yes. Eculizumab targets the complement system, which is a major driver of damage at the neuromuscular junction in many patients who have those specific anti-acetylcholine receptor antibodies. It's intervening very precisely in that pathway.
Okay, great overview of the categories and some key points. Now let's really dig into how they work. Mechanism of action. Step 1. Symptomatic relief. Acetylcholinesterase inhibitors like pyridostigmine. Let's unpack the mechanics.
So the name tells you a lot. Acetylcholinesterase is the enzyme that normally breaks down acetylcholine right there in the synapse, the neuromuscular junction.
Okay?
Pyridostigmine inhibits or blocks that enzyme.
So it stops the breakdown.
Exactly. By stopping the breakdown, you get more acetylcholine hanging around in that junction for longer. More acetylcholine means more chance to bind to the muscle receptors that are still working.
So it's amplifying the signal to overcome the fact that there are fewer receptors working properly in MG.
Precisely. It doesn't fix the underlying autoimmune problem, but it makes the nerve-muscle communication more efficient, boosts muscle strength directly.
Makes sense as a first line for day-to-day symptoms. Okay, let's move to step 2. Immunosuppression. First up, corticosteroids like prednisone. How do these manage to dampen the immune system in MG? They seem pretty powerful.
They are. Corticosteroids are very broad anti-inflammatory and immunosuppressive drugs. In MG, they work mainly by suppressing T-cell activation. T cells are key immune cells and reducing the production of cytokines.
It's undercut.
Yeah, signaling molecules. They promote inflammation and drive autoantibody production. So corticosteroids act higher up, reducing the overall autoimmune attack.
So kind of like a general dimmer switch on the immune system, not super specific.
That's a good way to put it. Their effects are widespread. That's why they can be very effective, but also why they have a broader range of potential side effects too.
Okay. Next is azathioprine and mycophenolate. The mechanism mentioned is inhibiting purine synthesis. How does messing with purines suppress the immune system?
Right, so purines are basic building blocks for DNA and RNA. Cells need them to grow and divide. Azathioprine and mycophenolate interfere with making those purines. This hits rapidly dividing cells hardest, and that includes the B cells and T cells driving the autoimmune attack in MG. Fewer building blocks means slower proliferation of these immune cells.
So slowing down the production line for new immune cells reduces the attack over time.
Exactly. It's a more gradual approach, takes longer to see the effects compared to steroids.
Then there's rituximab. Targets CD20 plus B cells, we said.
Yeah.
What's special about CD20 and how does hitting it reduce autoantibodies?
Okay, CD20 is a protein found on the surface of most B cells. Remember, B cells make antibodies, including the bad autoantibodies in MG.
Right.
Rituximab is a monoclonal antibody made in a lab that specifically sticks to CD20. This flags the B cell for destruction by the body's own immune system.
Oh, okay.
So by wiping out these CD20 positive B cells, you significantly cut down the production of the autoantibodies attacking the neuromuscular junction.
Like a targeted strike against the antibody factories.
That's a great way to think about it, much more targeted than the broader immunosuppressants.
And finally, for immunosuppressants, eculizumab. Binds C5, prevents formation of the membrane attack complex, or MAC. What is the MA and why stop it?
The MAC is sort of the final weapon of the complement system, part of our innate immunity. When complement gets activated inappropriately, like in some types of MG, the MAC forms these pores, like little holes in the cell membranes at the neuromuscular junction.
That sounds bad.
It is. It causes damage and dysfunction. Eculizumab binds to the C5 protein, which is essential for building the MAC. By binding C5, it basically stops the MAC from assembling.
So it's like putting up a shield to block that final destructive step in that specific immune pathway.
Precisely. Targeting a very specific damage mechanism in certain MG patients.
Okay, let's shift gears again. Step 3, acute crisis management, IVIG and plasmapheresis. Let's start with IVA. How does giving pooled antibodies from donors help? The idea of anti-idiotypic antibodies sounds complicated.
It is a bit complex. IVG is basically a concentrated mix of IgG antibodies from thousands of healthy donors. One theory is these anti-idiotypic antibodies. Think of your autoantibodies having a unique shape, the idiotype.
Okay.
The IVIG contains antibodies that can recognize and bind to that specific shape on the harmful autoantibodies, essentially neutralizing them.
Ah.
Plus, IVIG likely does other things too, influencing different parts of the immune system, kind of helping restore balance during a crisis.
So it's like a broad spectrum antibody mix that can counter the bad ones in various ways during that critical time.
That sums it up pretty well, using the immune system's own complexity against the problem.
And plasmapheresis. The document says it removes circulating autoantibodies. Sounds very direct.
It's very direct. Plasmapheresis, or plasma exchange, is a procedure. You take the patient's blood, run it through a machine that separates the liquid part containing the autoantibodies from the blood cells. Then you discard that plasma and replace it with a substitute like albumin or fresh plasma and return the cells to the patient. It physically removes the problem antibodies.
So just taking the bad stuff out quickly in a crisis.
Exactly. Leads to a rapid drop in autoantibody levels.
Okay, that makes sense for severe situations.
Yeah.
Now, let's talk pharmacokinetics, how the body handles these drugs. You've got onset, metabolism, excretion. Pyridostigmine first, quick onset, 30-60 minutes orally. How's it broken down and cleared?
Pyridostigmine is mainly metabolized in the liver, and then the kidneys excrete the metabolites.
Prednisone also acts pretty fast, 1-2 hours onset. Metabolism and elimination.
Prednisone is actually a prodrug. It gets converted in the liver to its active form, prednisolone.
Oh, okay.
Then both are mainly excreted by the kidneys.
Azathioprine takes much longer, weeks for onset. Where's it metabolized?
Excreted.
Azathioprine metabolism happens in the liver through a few pathways. One key enzyme is PPMT, the thiopurine methyltransferase. We'll circle back to that. Excretion is primarily renal, through the kidneys. Rituximab, onset days to weeks. Makes sense, depleting B cells takes time. Metabolism and excretion for a big protein like that.
Right. Large proteins like rituximab are mainly cleared by the reticuloendothelial system, part of the immune system that cleans up debris and foreign stuff. Some liver and kidney involvement too, but RES is key.
And IVIG, onset 24-72 hours. How's that cleared?
Well, IVIG is just adding more normal IgG antibodies. It doesn't get metabolized like a small drug. It's cleared through that same reticuloendothelial system, basically like the body's own natural antibodies over time.
Okay, helpful overview of how they move through the system. Now for clinical pearls, those practical tips. Pyridostigmine, short half-life, needs dosing every 3-6 hours. And avoid in bowel obstruction. Why the bowel obstruction issue?
Because pyridostigmine increases cholinergic activity everywhere, including the gut. It makes the gut muscles contract more. If there's a physical blockage, increasing contractions behind it could, worsen things, potentially even cause a tear or perforation. Very risky.
Critical safety point. Okay, azathioprine. Check TPMT enzyme activity before starting to avoid myelotoxicity. Why is TPMT so key for predicting side effects?
TPMT, that enzyme, breaks down azathioprine. Some people have naturally low levels or are deficient in this enzyme. If you have low TPMT activity, you break down azathioprine much slower. The active drug metabolites build up to high levels, and that significantly increases the risk of severe bone marrow suppression, myelotoxicity, low blood counts, infection risk, bleeding.
Wow.
So checking TPMT first lets you identify high-risk people. You can then adjust the dose way down or maybe choose a different drug altogether. It's crucial for safety.
Huge for personalizing treatment. IVG Pearl. Effects last 3 to 6 weeks. Monitor for aseptic meningitis. What's that and why with IVG?
Aseptic meningitis is inflammation of the brain and spinal cord linings, but not caused by bacteria or fungus. It's a known, though uncommon, side effect of IV. The exact why isn't totally clear.
What should you look for?
Symptoms like severe headache, stiff neck, fever, light sensitivity. Clinicians need to be aware it can happen after an infusion.
Good to know. Okay, let's tackle adverse effects. The document groups them by drug type. Cholinergic crisis from too much pyridostigmine, diarrhea, slow heart rate, sweating too much acetylcholine. Manage with atropine, reduce the dose. How does atropine fix it?
Atropine is an anticholinergic. It blocks the muscarinic acetylcholine receptors in the body, the ones causing those side effects like slowed heart, increased secretions, gut motility. By blocking them, atropine reverses those excess acetylcholine effects.
Got it. Immunosuppressants like azathioprine, risk of infections, liver toxicity, hepatotoxicity, often linked to bone marrow suppression. Manage with regular blood counts, CBC, and liver tests, LFTs. Why those tests?
Right. The CBC monitors white cells, red cells, platelets, all made in the bone marrow. Azathioprine can suppress that, so low white cells mean infection risk, low red cells mean anemia, low platelets mean bleeding risk.
Right.
LFTs check for liver inflammation or damage, another potential side effect. Regular checks let you catch these early and adjust the dose or stop the drug if needed.
Steroid side effects from prednisone. Osteoporosis, high blood sugar, hyperglycemia, examples of catabolic effects. Manage with calcium vitamin D, taper the dose. Why calcium and D?
Corticosteroids interfere with bone building and maintenance, increasing osteoporosis risk. Calcium and vitamin D are crucial for bone health, helping counteract that.
And the high blood sugar.
Steroids mess with glucose metabolism, often raising blood sugar. Tapering helps minimize this and other steroid issues by reducing the overall exposure.
Rituximab infusion reactions. Fever, low blood pressure, hypotension due to cytokine release. Managed by pre-medicating with antihistamines. How do antihistamines help there?
When rituximab kills B cells, it can trigger a release of inflammatory cytokines. These cause symptoms like fever, chills, low blood pressure. Antihistamines block histamine, a key player in these reactions, reducing their severity.
Makes sense.
Often premedication also includes acetaminophen, maybe even a small dose of steroids to further dampen that reaction.
Lastly, eculizumab. Increased risk of thromboembolism, blood clots. Possibly linked to complement inhibition. Managed by monitoring for thrombosis.
Right.
Why would blocking complement raise clot risk?
It's complex and not fully understood. The complement system interacts with the clotting system. It's thought that inhibiting parts of complement, especially the terminal pathway, might disrupt some natural anticoagulant mechanisms.
So just need to be vigilant.
Exactly. Careful monitoring for any signs or symptoms of clots is really important for patients on eculizumab.
Okay, that's a good rundown of potential downsides. Now, contraindications when not to use a drug?
Yeah.
Pyridostigmine. Absolute contraindication in mechanical bowel obstruction, as we discussed. Also, live vaccines with any immunosuppressant. Why is that such a big no-no?
Live vaccines use weakened but still living versions of the virus or bacteria.
Right.
In someone whose immune system is suppressed by drugs, steroids, azathioprine, biologics, their body might not control even that weakened pathogen. It could actually cause the disease the vaccine is meant to prevent and potentially a severe version.
Really important interaction. Okay, relative contraindications. Rituximab in active hepatitis B infection. Prednisone in uncontrolled diabetes. Why? Relative.
Relative means you might still use the drug, but you have to weigh the risks and benefits very carefully and manage the situation closely.
So for rituximab and Hep B,
Rituximab's immunosuppression can let a dormant hepatitis B virus reactivate, causing serious liver problems. So you screen for HBV first. If active, treat the HBV and use rituximab only with very careful monitoring.
and prednisone with uncontrolled diabetes.
Prednisone raises blood sugar, making uncontrolled diabetes even harder to manage. But if the steroid is absolutely necessary, you might use it, provided you aggressively monitor blood sugar and adjust diabetes meds accordingly. It requires extra vigilance.
Okay, covering a lot of crucial safety ground. Next, drug interactions. Pyridostigmine plus beta blockers increases bradycardia risk. Why the additive effect on heart rate?
Both can slow the heart. Pyridostigmine increases acetylcholine, which slows the heart via muscarinic receptors. Beta blockers block adrenaline's effect, also slowing the heart. Together, the effect can add up, potentially causing dangerously slow heart rate.
Azathioprine plus allopurinol increases myotoxicity risk. Allopurinol is for gout, right? How does it interfere with azathioprine breakdown?
Right. Allopurinol inhibits an enzyme called xanthine oxidase. This enzyme is actually involved in breaking down one of azathiopurine's active metabolites.
Oh.
So block xanthine oxidase with allopurinol and levels of that active metabolite go up, increasing the risk of bone marrow suppression. If you must use them together, you typically have to cut the azathioprine dose dramatically.
Good to know. And eculizumab avoid live vaccines, as we discussed for immunosuppressants generally. The document also has a really useful exam tip. Steroids can initially worsen MG weakness. Start low, go slow. That seems counterintuitive, but vital.
It is absolutely vital. Patients need to know they might feel a bit worse before they feel better on steroids. Starting low and increasing slowly minimizes this initial dip and lets the body adjust. Prevents unnecessary panic, too.
Yeah, managing expectations.
Yep.
Okay, the doc then dives into more specifics on dosage and more clinical pearls. Pyridostigmine doses, initial, frequency, max, even pediatric. Prednisone crisis doses, taper duration, IVIG, rituximab doses. Clearly, getting the dose and schedule right is critical.
Absolutely. Precision is key for both effectiveness and safety with all these medications.
There's also a pediatric note. Long-term steroids can stunt growth. Need for height monitoring in kids, that's a huge consideration.
Huge. You're always balancing the benefit of the steroid against that potential long-term impact on growth in children. Requires very careful thought and monitoring.
Okay, toxicity and management, we hit cholinergic crisis. The myasthenic crisis itself, severe respiratory weakness. Treat with plasmapheresis VIG, maybe intubation, really highlights the role of those acute therapies.
Yes, these aren't drug side effects, but managing the disease flare itself.
Yeah.
Critical interventions.
And steroid-induced psychosis, hallucinations, agitation, managed by tapering steroids, maybe antipsychotics, a reminder that these drugs can have significant mental health effects.
Absolutely. Psychiatric side effects are real and need to be recognized and managed as part of comprehensive care.
Now, the black box warnings and keynotes are really serious stuff. Rituximab, potentially fatal infusion reactions, HBV reactivation, reinforces the need for premedication and screening.
Definitely. These are the highest level warnings.
Tocilizumabs, meningococcal infections, mandates vaccination before starting treatment. That's a big one.
Absolutely essential safety step for eculizumab.
Azathioprine. Myelosuppression, hepatotoxicity, echoes what we discussed about monitoring. These warnings really drive home the need for vigilance.
They do. They ensure everyone is aware of the most significant risks and takes appropriate precautions.
The document also flags a high-yield fact. The edrophonium, or tensilon test, helps differentiate myasthenic versus cholinergic crisis. Temporary improvement points to myasthenic crisis. Classic neurotool.
Still valuable at the bedside, though you need to be cautious, monitor the heart, because edrophonium itself can have side effects.
Right. Okay, finally, the final exam checklist, great summary, highlights the core mechanisms, AHE inhibition versus immunosuppression.
The two main strategies.
Crisis management, IV plasmapheresis for myasthenic, atropine for cholinergic, monitoring essentials, AChR antibodies, lung function, TPMT status.
Key things to track.
Thymectomy indications. Thymoma or generalized MG in younger patients, typically under 60. And a final warning. Avoid aminoglycoside antibiotics. They can worsen the neuromuscular blockade. This checklist really pulls it all together.
It's a good recap of the must-know points for myasthenia gravis drug therapy.
So, wrapping up this deep dive, we've covered a lot of ground on the drug management of MG. We looked at symptomatic relief, immunosuppressants, crisis treatments, thymoma context.
Yeah, and stressed not just what the drugs are, but how they work, the mechanisms, pharmacokinetics, side effects, interactions, warnings, the whole picture.
It's really